Afternoon, everybody, and welcome to this afternoon's Journal Club on integrated IPC and antimicrobial stewardship, a global perspective. And it's being hosted today by IPC Partners in conjunction with the Healthcare Infection Society. So I'm your chair today. I'm Lisa Ridgway. I'm a retired consultant microbiologist from Sheffield. And I'm currently president of the Healthcare Infection Society, and it's really great to be taking part in this session. I'm sure it's going to give us lots of food for thought. So HIS has recently published a special issue on integrated IPC and AMS strategies in the Journal of Hospital Infection, and the papers being discussed today are taken from that. So if you'd like to read more on that and further papers, then have a look. And while I remember, the Journal of Hospital Infection is actually currently recruiting a couple of new editors. So if you're interested in that, I'll put up a slide later which has a QR code which you can scan for some more information. So briefly, today's session is going to run like this. There'll be 2 talks from our presenters and then time for Q&A at the end of each talk. As we go along, I'd really encourage you to put some questions in the Q&A function. So rather than the chat function, put it in the Q&A function. And if you see things that you think are really important, then can you like those? And then we will know that those are being particularly highlighted, and we'll try to get to as many as we can. So with that, I'll pass you on to our 2 speakers, Phil and Jon. Would you like to introduce yourselves?
Yeah, hi Lisa, thank you. My name's Jon. I'm Director of IPC at Guy's and Tommy's, and looking forward to speaking later about integration of IPC and AMS, or should I say lack of integration of IPC and AMS, in fact.
Thanks very much, Lisa. Good afternoon, everybody, or good morning, depending on where you are in the world or where you're watching this. My name's Dr. Phil Norville. I'm the Chief Executive Officer at IPC Partners, and I've worked in infection prevention control for around about 15 years. I'm going to be talking about a novel decontaminant, something called cold plasma, and its potential use in environmental decontamination. Thanks, Lisa.
Thanks. So before we get into the talks, the thing that struck me is that both of these papers, they have a common theme, which is infection control in environments and settings that are perhaps not as resource rich as we're used to, and how we can apply innovations that will support those. Was that your impression?
Yeah, very much so, Lisa. And I think when we're looking at learning or information coming out of resource limited settings, it can be easy to say, oh well, why aren't they doing this, why aren't they doing that? I mean, one of the findings in the study I'm going to cover is that only half of the hospitals had a microbiology laboratory. So imagine practicing either IPC or AMS in that setting. But I do think there's actually some learning that we can take in a more developed healthcare system from the kind of workarounds and innovations that are put in place in the low and middle income countries that can actually help us with some of our issues as well.
Great. All right then. Well, I think Jon, you're going first, Jon.
Yep, I'm up first.
All right, so I'll hand over to you now to talk about your presentation on fighting antimicrobial resistance in a resource-limited setting, an integrated approach. Thanks.
Okay, thank you, Lisa. Thanks, everybody, for joining us today. Just before I get into my paper, just a little bit of background on the Journal Club itself and what we're trying to achieve here. We're looking to provide some insight, hopefully, into topical IPC papers. We love the discussion, so please do get your questions come into the Q&A. Don't leave it too late, because if you submit your question late, it'll be on the bottom of the pile and we might not get to it. There's some natural opportunities here for CPD. We want you to exercise your critical thinking skills. So we love a bit of disagreement. If you hear something you don't think tallies with the paper, you know, put something in. Let's have a discussion about it. We want you to go away from here feeling confident about independent research and study. I think you are here as a network of enthusiasts, and we're grateful for that. And if it's possible, in a subject that can sometimes be a little dry, we do want to have a little bit of fun as well. So this is the paper I've chosen today. It's fighting antimicrobial resistance in a resource-limited setting, and looking at whether there is an integrated approach to IPC and AMS, antimicrobial stewardship, and putting that forward as the so-called best buy, which is an odd choice of terms, but I'll move on from that. So why I chose this article, briefly, the combined threat from healthcare-associated infection and antimicrobial resistance is the most pressing threat that we're facing, and each of us here has a critical role to play in working towards some solutions. The article stood out because it's got some data from Sierra Leone, which is a very interesting country that we'll come on to in a bit. It's a lower middle income country. In fact, it's a low income country. And it illustrates some practical and scalable ideas around the integration of IPC and AMS in that setting, which I think we can learn from wherever we happen to be practicing in the world. I think the study design looking across multiple hospitals and hospitals of different types was quite appealing as well in terms of raising points for discussion for those of us from a range of different backgrounds. So Sierra Leone, could you find it on a map? I'm not certain that I could, but there it is on the west coast of Africa. It is a low income economy, possibly the lowest income economy you could probably come across, considered in the top 5 poorest countries, or should that be the bottom 5. Average life expectancy only 60 years, 71 deaths per 1,000 live births, almost 1,500 maternal deaths per 100,000 live births. That's a rate of 1.5%. And interestingly, I think importantly, a low density of healthcare workers. So they just don't have the people around to deliver the healthcare systems and processes in the way that they would like. So in this context, this is the study design. It was a cross-sectional survey undertaken in October 2024, and it involved 12 hospitals, 6 of which were secondary and 6 tertiary. So there was a mixture of providers there and geographically dispersed across the relatively small country that is Sierra Leone. Hospitals needed to have a pharmacist to be an AMS focal point and an IPC person to be an IPC focal point. And they also needed to be participating in the National Antibiotic Use Prevalence Survey as well. The survey used a range of selected indicators from the WHO AMS toolkit and also the IPC core components. That's 2 separate WHO documents to assess infrastructure, policy and practice. And they collected their data using a nice short online survey and went to the pharmacist and the IPC lead for each organisation jointly to complete the survey to try and retain some consistency of information. And this is what they found. I think probably unsurprisingly, there were some pretty sizable infrastructure gaps. Whilst all hospitals had an IPC program, that's a good thing. Only 1 in 4 had a formal AMS committee, and all of those were in the tertiary hospitals. And I think it's also fair to say the IPC programs, whilst the article didn't go into this in detail, were also variable in terms of the scale that they were operating on. Laboratory access was a real limitation. Only half of the hospitals had access to a micro lab, and most of these were in tertiary settings. So, imagine trying to deliver either an IPC program or an AMS program without a microbiology laboratory. You'd find yourself fighting in the dark an awful lot of the time. There were also some pretty significant deficiencies around policy and practice. So more than 9 in 10 lacked AMS education and training. All of them lacked a formulary for antibiotics. 9 in 10 just over lacked prescription treatment guidelines, and 8 in 10 just over lacked AMR and antibiotic use surveillance. So many of the kind of cornerstones of antimicrobial stewardship that we rely upon day by day, or most of us do, and that will depend where we're working in the world, of course, are just not there. One of the hospitals stood out as what the authors considered an example of best practice, Connaught Hospital, and that had, interestingly, a joint IPC and AMS committee, and this is something that the authors promoted as a really strong idea to hang the AMS agenda onto an established IPC committee, which is a good idea in principle. So what are strengths and limitations? Well, it was a multi-site design across more than one hospital and more than one hospital setting and region, and that adds strength to the study design. Using the standardized WHO tools, the AMS toolkit and the core components allowed them to have some sort of infrastructure to their comparison to allow comparability and relevance as well. It highlighted a potential solution, this idea of combining the AMS committee and the IPC committee. So that was a good thing. On the flip side, some limitations, it was a convenient sample. So it wasn't aiming in any way to be a comprehensive survey of all hospitals in Sierra Leone. So that may limit generalizability, and of course just the fact that this is only in Sierra Leone, so it doesn't give anything like a global perspective. Self-reported data, as is always the case, could introduce bias, and the study did not assess clinical outcomes or link AMS or IPC practice to outcomes or trends directly. So I think this top point for discussion is really the big question from this study. Would the model of integrating IPC and AMS as programs work in all settings? And if I think a little bit about my own hospital group in London, and just how much ground we have to cover in, say, a typical IPC committee or a typical AMS committee, if we combine the two, it would be an enormous undertaking. And trying to get the people together for long enough to actually go through the information we need to cover, I'm just not sure that it would work. So I think if you have a really fully established IPC and AMS program, this idea may not work. If, however, you're just starting out or you're working in a low resource setting, as was the case in this study, then I think there's a lot of value in the idea of combining the IPC and AMS committee. And because each of the hospitals already had an established IPC committee, you could quite easily hang an AMS group onto that. And that strikes me as a pretty good idea, and one that has mileage. Many of the same people are around the table for IPC and AMS. Many of the same challenges around stakeholder engagement outside of the world of IPC and AMS are true for both. So I think there's potential for integration for sure. How can secondary hospitals in low and middle income countries be supported to establish AMS programs? One of the striking findings was that the only hospitals that had AMS programs were the tertiary hospitals, whereas the secondary hospitals are dealing with infection day in, day out, and I'm sure overusing antibiotics as a result of not having an established AMS program. What are the barriers to implementing antibiotic formularies and treatment guidelines? These things are crucial if we're to gain proper control of prescribing and dispensing. How can laboratory structures be strengthened? I'm not sure anybody on this call has the answer to that. I think this has to do with complex issues around funding of healthcare infrastructure, but any ideas welcome. Do there need to be stronger national mandates for IPC, AMS programs and the integration of them both? In this country, we have the Health and Social Care Act, which sets out clear recommendations around, actually clear requirements around what we need to have and what we need to cover. And what about training and surveillance? How can it be scaled in resource limited settings so that we do get some at least information around what's going on with trends? Because one of the gaps identified in this study was in surveillance. So just before I conclude, I want to try and do something slightly different, because I think this question was thrown up by this study in my mind. There's a couple of different models or ways that we could look at the interaction or the relationship between an infection prevention and control program and an antimicrobial stewardship program. And I've had many hours of discussions with colleagues about this, around how should we view this? What should the hierarchy be? How should it be interpreted? So do we think it's more like A, where AMS is a subsection of the IPC agenda, along with things like outbreak management and surveillance and environmental IPC? Or is it B, are they co-equal? Do we have IPC and AMS not directly connected, but working in parallel? Is it more like C? Are they Venn diagrammed together, where you get significant areas of overlap, but still independence in the programs? Or is it even like D? I've heard this argued to me more than once, that antimicrobial stewardship is the overarching program, and IPC is a subsection of that program. So if the poll is working right, it should have popped up on your screen. So decide which one you think is the best fit. And let's see. So I can see 25 people have responded, so thank you. Keep those results coming in. And we'll keep that poll running for a little while longer just to see what the responses are. And I'm going to leave that slide up while we get a few more responses, and then we can comment on that. So if we can leave that poll running just while I conclude. So the study reinforces the critical role of IPC as a foundation for AMS, for sure. IPC structures seem to be a bit more established and could serve as a launchpad for AMS, and the IPC program could be used to leverage or accelerate antimicrobial stewardship implementation. And the aim of both programs ultimately is to improve patient safety and to turn the tide on antimicrobial resistance. So I'm going to back up to the slide here that gives you what the ABCDs mean in the poll. And we can keep the responses coming in for a little while longer as we move into the Q&A.
Oops. Thanks, John. Can you hear me? My microphone. Oh, there we go. Can you hear me?
Yes, I can hear you now.
Great, jolly good. Thanks very much for that. Yes, I thought it was a very interesting paper. I sat there and I got my Google Maps out and I looked at where all these different hospitals were, the ones that I could identify. And what struck me was about half of them were actually in Freetown, which obviously is the capital town, with a population of about 1.25 million, I think. And one thing that struck me was, do you think putting IPC and AMS together is going to be more effective than just getting hospitals that are close to each other and even far away from each other to work collaboratively on things like policy development, strategy, guidelines, training?
Yeah,
I just slightly feel that, certainly in my experience, IPC teams are already massively overburdened with all sorts of stuff. And it's slightly, I can see I agree with what you mean about if you're starting out at the beginning, it's a good idea to run the streams in parallel. So I just wondered, do you think it's better to have a broader umbrella or actually to bring those centres that actually do have some infrastructure together to work more efficiently?
I think probably we need to work towards local implementation of an IPC and an AMS program on a system level. That might be a group of hospitals or it might be individual hospitals, depending on how things are configured. I think structures that go across different hospital groups tend to be less powerful and less owned than those that are within the groups. So I'm thinking of maybe a rough parallel is how much influence in the UK and the NHS the integrated care board approach has versus an individual trust. And actually, it's really the individual trust that drive policy and practice rather than the boards across them. Now, that things may be different in Sierra Leone, and in a resource limited setting, perhaps it is a good approach and a good line to follow.
Yeah, it also struck me that it said, I think, that the average bed capacity was 192 across the 12 hospitals. But that includes several that are 500 or 600 beds, which are going to skew it heavily. So I suspect that quite a lot of those hospitals are very small. Do you think it's realistic to expect them to have a fully functioning IPC AMS system that ticks all the boxes for the WHO components and so on?
I think for the core components, yeah, I don't think that's a completely unreasonable expectation. I think if it's a very small centre, then actually a combined IPC and AMS committee makes complete sense because it would be an efficient use of resources. I wonder whether we might just talk to the poll. I think most of those who have voted are going to vote now. So
Okay.
just looking at the results there, it seems that 83% of those who responded felt that C was the best visual representation of the relationship between IPC and AMS, where we've got the Venn diagram and them co-equal. That was my vote. What did you vote for?
I voted for C.
For, yeah, me too.
Did you say C as well? Yeah.
Yeah, that was my experience when I was working in Oxford, and the kind of antimicrobial pharmacist team, and the pharmacy team played a huge role in lots of different decision-making processes around, treatment of C. diff patients and antibiotic prophylaxis. So yeah, that's my vote C. I definitely think that there's that overlap is really important.
I wonder, so when I was working, we had separate committees precisely because of what Jon said, is that each committee was almost a whole day's worth of work on its own. And combining them, everybody would have just found an excuse not to come. But certainly, I think there should be significant representation from one committee to the other, even if there isn't. I wonder if there's anywhere where that doesn't happen.
Yeah, I'm sure that's true. I mean, I've heard stories of IPC and AMS existing in bubbles and never the twain shall meet. Right. Literally on separate floors of the hospital, and kind of tension between the two, almost a bit of a power struggle between the two committees in the hospital, a bit like some kind of awful soap opera. So I'm sure it does happen. I'm happy to say in my organisation, it definitely doesn't feel like that. There is good kind of cohesion between the two committees. I think there's always more requests for cross talk and collateral working than is possible. So I think there's always more opportunities for integration.
Yeah. We've got a comment. It says it's not a question, it's more of a comment. I work in community IPC in non-acute settings in Ireland, covering a whole range of services across geographic areas. We have one senior AMS pharmacist, an epidemiologist, half a microbiologist, and a full-time IPC nursing team. Our HCAI committee of old is now an IPC AMS committee, and they felt that achieves the greatest benefit for the resources that they have. So I think that's very interesting, and I wonder whether is it easier to develop a combined model in a smaller setting than it is in a giant teaching hospital?
Yeah, I think it is. I think it very much is. So in that kind of community IPC service, it looks like it's working well and reaping some benefits. It wouldn't work in my organisation. It's too big. There's too much ground to cover. But I think if the organisation was smaller, perhaps even a single hospital, then a combined committee could work quite well. And there's perhaps some middle ground options where you have two, separate committees, but almost reporting to an overarching committee. That's something that might work as a structure.
Yeah. What's your experience, Phil?
I think I'm in agreement with Jon. I think it's probably changed, and there's been more focus on the collaborative approach in recent years. I think that's driven by more of an awareness of the risk of AMR and the need to be more prudent in the prescribing of antibiotics, but also the fact that we are running out of treatment options as well. So in those options that we do take, it's really important that we do get that combined thinking, that combined ways of working to ensure that the two kind of assist and work together in collaboration and in tandem. Lisa, just while I've got the floor, there are some questions that have come into the chat and not the Q&A.
Oh, okay.
if you can't see them.
You want to lead off with those then?
Yeah, I'll take one of them.
Oh, right. You take one of those then.
Yeah, okay. So Jon, do you think there is enough AMS training for prescribers generally, and would that be something you would pick for an AMS IPC program in low middle income countries?
I think it's probably true that no matter how much training was being provided, the answer to that would always be no. As in, there's always going to be more that we can do to make prescribers better informed about antibiotic prescription, especially. And I think increasingly the role of an antimicrobial stewardship program is to encourage people not to prescribe and to shorten the dose, etc. And I'm sure that would be true in any setting. So I think yes to more training, and training angled towards building confidence to not prescribe in the first place, or to de-escalate therapy as quickly as possible. I would add, though, I've never actually done any work in a lower middle income setting at all, so I have no insight to bring on that.
Yeah, I find it quite difficult to comment without appearing to be, you know, privileged and a know-it-all. One thing I wanted to say is the WHO IPC unit has worked and produced a huge amounts of material for the core competencies, and they have done surveys for IPC and so on. Do you think the fact that the office has kind of had its feet chopped out from under it is going to significantly hinder progress going forwards?
Yeah, I do, and I think there's a question from Uzoma in the chat around frameworks that have been trialed and implemented in some settings that could be almost dragged and dropped, maybe modified for a resource limited setting. And I think some of those resources that you mentioned there are exactly the sort of things I'd point to. There's some really, really powerful resources out there available from various different organizations, governments and charities, etc. So there's a lot of information. I think it's almost a case of requiring a bit of expertise and focus to understand the need in the lower middle income countries, because you can't just take something that may or may not work in a more developed healthcare system and expect it to work well in a low middle income setting. So I think it's that local intelligence and understanding of what the need is and which of the resources are the best fit, because you could spend a lot of time reinventing the wheel.
Yeah. One thing I thought was interesting, I looked back at the 2018 WHO survey, and Sierra Leone actually took part in that survey, one of the very few countries in West Africa. And it's interesting that given the output from that survey, well, 7-8 years ago now, there were still huge gaps in their IPC infrastructure and resourcing. So identifying what the issues are doesn't necessarily translate into improvement, does it? Unless there's a will right from the very top.
Yeah.
Yeah. Okay, brilliant. Any other questions in the chat? Oh, I think someone's highlighting something that's an issue for everybody. Community IPC team here. Our bi-monthly AMR meeting is organised by the local ICB. We find it poorly attended and rarely have a microbiologist in attendance. So it's not just low and middle income countries that struggle to get engagement, is it?
Yeah, it's true. And I think microbiologists, we don't struggle with engaging, you know, they're part of our team in the hospital. So that's no problem. But it's the clinicians, particularly the medical staff from the wider organization, getting really strong engagement on either IPC or AMS. That's a trick.
Yeah, we used to find we'd get registrars from the various teams on the committee for their CV.
Right. Yeah.
But their involvement didn't really go further than that. So yeah, you need the right people. As with everything, you always need the right people to make things happen. Okay, great. Thank you very much. Thanks for your comments, everybody. So now we're going to move on to Phil, who's going to talk to us about cold atmospheric plasma decontamination. And I'm glad he's going to talk to us about this because I don't know anything about it at all. So over to you, Phil.
Thanks so much, Lisa. I have to admit, I didn't know anything about it at all, so I had to do a bit of my own learning and teaching. So yeah, hi everybody. Great talk, John. This is a very different kind of topic that I'm going to be talking about when it comes to the role of the environment in tackling healthcare-associated infections and antimicrobial resistance. So why did I choose this paper to begin with? One of my passions and a lot of my experience working in infection prevention control is the role of the environment in the transmission of healthcare associated infections. We've got probably the best evidence to date that the healthcare environment plays a tremendous role in the transmission of certain infections. We know that organisms persist in the environment for prolonged periods of time, and therefore ways in which we can clean and disinfect and decontaminate the environment effectively are really interesting because they can potentially reduce the risk of transmission if they're done correctly. I'm also interested in novel technologies. This kind of paper brought me back, 10, 15 years ago when we first started to talk about the use of ultraviolet light. We've known about hydrogen peroxide vapor for a long period of time in its role in automated room decontamination. So it reminded me of a novel technology in UVC, which we now see quite an abundance in certainly the UK and the US healthcare system and its role in environmental decontamination. So I thought, is this the new next emerging technology? I wanted to find out more about it. And I just have to admit, I didn't hear about or know about cold atmospheric plasma. And it sounds pretty cool as well, doesn't it? It sounds like something you would hear in a NASA briefing or something like that. When I started to dig into it a little bit more, I also found out that it had been used in lots of other applications. So in things like wound care and skin healing, also in the dental industry, in treating implants. So I was really interested to see how that could transfer over into infection prevention control and how it could potentially be used as a decontaminant, sorry. And I guess the link here with AMR is that if we can kind of reduce the spread of these infections, we reduce the need for antibiotic usage and we lower our AMR pressure. So that's kind of where the link of the environment and environmental decontamination comes in here. So hopefully this answers Lisa's question. CAP, or cold atmospheric plasma, is generated by applying an electrical field to a gas, and there's a list of some of the ones that are used there, and atmospheric pressure. And essentially this generates an ionized gas, but it's at room temperature, and that's really vital because that means it doesn't burn or damage equipment or medical devices. So already you can start to see how the generation of this ionized gas has a potential application because it is safe to use in terms of not damaging surfaces or equipment. What that process does is it generates these really powerful reactive species by the action of these plasma-induced radicals. And I've just listed a couple of them here. Some of these they're not all listed, but hydrogen peroxide is a very powerful oxidizing agent that we know about from environmental decontamination and disinfection previously. We know it's a very good disinfectant, but these powerful radicals or reactive species are produced through this process of passing this electrical field to a gas and generating these really powerful antimicrobial agents. And there's actually lots of work that's been done to show that the efficaciousness of some of these reactive species is very good and active against both bacterial, fungal and viral pathogens. And in the paper, which is actually a commentary, which is a really important thing for me to state, talking about how this potentially has an application as an environmental decontaminant, they talk about the application method. So a lot of the studies that I read as part of my research when I was looking into this paper talk about it being applied in things like a liquid, but actually the authors are talking here about how potentially the role as an environmental decontaminant could be as a mist or a vapor, similar to what we do with hydrogen peroxide vapor, for example. Then I've read a couple of other papers and they've talked about it in a liquid as well. So we use liquid disinfectants in the forms of wipes or solutions like chlorine. So is there a role for a liquid kind of or cold plasma activated liquid for environmental decontamination as well? So this just kind of summarizes a little bit how it works. This is taken from another paper published in Viruses in 2022. So you can just see here how you've got this kind of electricity being applied, and then you get these production of the different radicals. And this schematic just shows you how it impacts really broad spectrum against a bacterial cell. So it isn't just a sole mechanism of action. And that's, I think, quite a common thing that we should be familiar with when we're talking about the role of disinfectants. And one thing I really wanted to highlight is that when we think about antimicrobial resistance, we sometimes think about disinfectant resistance as well. Disinfectants typically work in different ways to antibiotics. Antibiotics tend to be very a sole mechanism of action. So they act on one cellular process, whereas disinfectants, they tend to maybe attack 2 or 3 different processes in the bacterial cell. And cold plasma does that as well. So it's a really interesting candidate here because you can see it's not just attacking the DNA or the nucleic acid, it's impacting on the cell wall, the cell membrane, lipid and fatty acid synthesis, and also proteins and enzymes. So you can just start to get a feel for how it generates this really broad spectrum activity and also has a low propensity for generating resistance, because if you're targeting the bacterial or the viral cell in lots of different ways, it's a lot more difficult for the organism to develop resistance. If you're just targeting one process, the organism just has to do one mutation to potentially give it resistance to that. Whereas if you're targeting multiple, you're asking for multiple mutations to provide resistance. So again, this is why I think cold plasma is a really interesting and promising alternative. My other research just showed, to talk about this as a novel concept, but just talking about how it's being used in other areas and other therapeutic areas. So looking at in oral and biofilm related infections, looking at it across various biomedical fields, looking at it in the human body for therapeutic purposes, therapeutic advancement, sterilization, oral dental disease, and various applications in the medical and biomedical domains in things like wound care and skin healing as well. So, cold plasma is this idea for an environmental decontaminant, or to be used as an environmental decontaminant, but it has multifaceted biomedical applications, which again, I think is, when you see a new technology, knowing that it's being used in other areas and other industries gives me a bit of assurance, actually, that we know a little bit more about it, and it isn't something, that we know little about, and we're worried about the safety and the regulatory aspects, because if we're using it, in dentistry, or we're using it in prosthetics, we know that there must be some research and safety considerations that are already being identified. So what are the advantages? And lots of these are highlighted by the commentary that we're focusing on today, published in the Journal of Hospital Infection. It's broad spectrum, as we've already alluded to, mainly because of that multiple mechanism of action. There aren't any reported resistant mechanisms to cold plasma. And one of the key things that this paper highlights is its potential to be used when patients and staff are in the room, which is very, very different to our traditional automated room disinfection machines like ultraviolet light or hydrogen peroxide vapor. And this is because atmospheric cold plasma, or CAP, isn't genotoxic to human cells, so it doesn't damage the genetic material of our human cells. So the authors don't really talk too much about how that might work. They talk about it being present in maybe a mist or a vapor, but there's still work to do, I think, about the delivery mechanism and the application in a clinical setting. But of course, I think if you work in IPC, you know how difficult it is to get your rooms free to be able to do a deep clean or a terminal clean, particularly in multi-bedded bays. Easier inside rooms, of course, when patients are discharged. But if you could have something that was maybe constantly running in the background to reduce those levels of contaminants on surfaces and potentially in the air, then I think that's a real attractive step from atmospheric cold plasma. And the other thing, which I'm going to touch on really briefly in the next slide, is also got really good activity against biofilms. So actually, before I talk about biofilms, I'm just going to talk about this study, which is published in JHI, talking about CAP as a potential decontaminant. So in this study here, just to really illustrate the efficacy of CAP, they basically contaminated cleaning cloths with E. coli and MRSA. They put the cleaning cloths in a broth overnight, and they grew lovely E. coli and MRSA. So imagine that cleaning cloth covered in E. coli and MRSA, and then they treated it with a cold atmospheric plasma or a liquid that had been activated with cold atmospheric plasma. They left it for an hour, which is why I've put this question mark around the contact time, but you can see there's some really good reductions there in bacterial viability. And the authors in this paper do point out that more work needs to be done to make sure we can refine that contact time. But I think this is just a proof of concept that it does work. And if we are talking about potentially reusing cleaning cloth products, use of microfiber, for example, could something like CAP be used as a disinfectant in combination with them? Obviously, there might be a sustainability win there as opposed to things like single-use antimicrobial wipes, which we use once and throw away. So just illustrating here that we do have some efficacy. And then again, we talked about biofilms, and the commentary talks about the activity against biofilms. This is another paper published in JHI and showing the activity of cold atmospheric plasma against different biofilms of different ages formed by methicillin-resistant Staph aureus. So you've got biofilms formed from 24, 48 and 72 hours. So the longer that the biofilms have had to grow and mature. And these bars here just show you the log reduction. So you can see even within just 60 seconds contact time with the cold atmospheric plasma, you're starting to get kind of a 99% or 2 log reduction. As you extend that over to 180 seconds, so just 3 minutes, you're getting over a 5 log reduction against biofilms of different maturity, which is a really important consideration as well. So I think I've just tried to take some of the things that the commentary has shown about the efficacy and the role and just put a bit more meat on the bones, really, to show that it is efficacious and has a real interesting potential against things like biofilms that we know are a big challenge from an IPC perspective. So what does the commentary say about the future? Well, it says that we need a lot more research to make CAP a pragmatic and usable technology in the healthcare setting, which I really agree with. There's a lot of work to do to optimize the delivery to be able to apply to surfaces, particularly so you can apply it to relatively large surfaces like floors or mattresses. I'm trying to think about the biggest things that we use within healthcare. Need to do more work around validating the claims in a healthcare setting. A lot of the data, the commentary says, is conducted in laboratory settings. So we need to talk about how that translates across the healthcare setting. Also need to think about residue. If we're treating surfaces with CAP over a prolonged period of time, does that build up any nasty residues? We know with hydrogen peroxide vapor, for example, we have to let the concentrations in the atmosphere reduce to safe amounts. So are the same considerations here for CAP? And one of the things that the authors do point to in this commentary is that there is potential for the accumulation of toxic gases such as ozone. So again, it's just being more aware of understanding some of the safety considerations when it comes to this as a potential environmental decontaminant. So what does this all mean for IPC? I think that it's a really interesting commentary because it highlights the importance of innovation, which I think we need to do more and more in IPC. We're talking today in the context of AMR, which is an evolving threat which affects all of us within healthcare. We can't afford to stand still, therefore we need to innovate and look at new technologies such as CAP. The idea that it can be used in the presence of patients and staff, I think, is really promising, but obviously more work needs to be done on understanding the safety and the application. I also think it really reminded me of whether or not we put enough focus on anti-biofilm activity of our disinfectants. I think in the last 5 years, we're seeing more and more research talk about the role of biofilms in the transmission of healthcare-associated infections and also the potential transmission of antimicrobial resistance genes through mobile genetic elements. So do you need to be talking more about the role of our environmental decontaminants in reducing biofilms, particularly in wet environments? But what about dry surface biofilm as well? Do we have activity against these biofilms that persist in a dehydrated state, particularly on surfaces? Obviously, we think that cold plasma should complement and not replace our manual cleaning. So this is a disinfectant. It isn't going to remove organic matter, so it needs to make sure that it fits in with our current manual cleaning processes. And also, is there a potential, touching on what Jon's point in his previous talk was about the development of IPC and AMR strategies in lower and middle income countries, could we make this a simpler and cheaper to run system than existing technologies, giving us an option for a resource limited setting as well? But ultimately, the paper calls out for the need for more research in the application and the safety and the regulatory considerations. So that's me. I'm going to stop sharing and hand back to Lisa, and hopefully there's some Q&A.
Thanks, Phil. I've got certainly some questions. So presumably the vision is that this will be a bit like a peroxide vapor machine that you wheel into a space, and it runs its cycle for however long. Doesn't sound very long at all, actually, from what you've said. And then depending on how toxic it turns out to be, there's going to be a more or less requirement for a fallow period afterwards for purging and that kind of thing. Is that, if I got my head around that, is that how you envision it?
Yeah, I think so. I mean, when the commentary talks about a mist or a vapor, I had this image of it potentially being kind of mounted in the ceiling and slowly kind of, dispersed into the ward or the clinical setting. But yeah, I think you're exactly right in terms of rolling it in as the way that we do with hydrogen peroxide vapor. I think I couldn't quite find more research on the safety element, but the fact that it isn't toxic to human cells, and the commentary calls for why it might be an interesting technology, because you can use it while people are in the clinical setting, which obviously would be a massive advantage over other automated disinfectant.
I found it a bit hard to get my head around that, because on one hand it says it's not toxic because there's no effect on the human genome, and yet it's pumping out reactive oxygen species and ozone, which are clearly irritant, if not teratogenic or whatever. So I think it sounds like there's going to have to be a lot of toxicity data available before people are going to feel able to have it in the presence of patients and staff. Certainly on a longer term basis, if people are going to be chronically exposed, you can kind of start to feel a bit uncomfortable about the occupational health aspects of chronic exposure. Definitely.
There's a lawsuit there somewhere.
Yes. Do you know if any commercial companies what do you think, John? Do you agree with that?
No, I do. I'm skeptical about this idea of using this sort of technology in an occupied space. If it has the capacity to get a 5-log reduction across a range of bacterial species, I just can't see how it could be safe to have in a room for continuous exposure. Part of it may be to do with, we're talking about cold atmospheric plasma, but it presumably is not just one approach. Within that, I guess you've got a range of production methodologies, a range of concentrations.
Yeah.
So that may be a factor in kind of optimizing efficacy versus safety. I don't know whether that came across at all, Phil. Anything about dosing or different type production methods?
Different application methods in kind of the other studies that I looked at and referenced. So slightly different, ways of application depending on the paper that we looked at, whether or not it was biofilms or looking at the application in on cleaning cloths. But I didn't see much in my research. I mean, I didn't go into detail because I was trying to attribute other studies to what I'd read in the commentary, but I didn't see a great deal from a environmental decontamination perspective, certainly about available systems and talking about how they actually generate the cold atmospheric plasma. So I think it is still in its infancy, but I think my takeaway message is that it's a potential novel technology that I think needs to be explored a bit more detail.
Are either of you aware of any commercial companies who've picked this up and are actively developing it yet? Thinking about, how long is it before we might see this kind of technology coming into use? I guess the answer is no then.
No, I'm not. I'm not. I haven't seen anything using this kind of technology. Phil?
No, I haven't. I've seen it in the other applications that we talked about, so potentially in kind of the wound or the oral care side of things, but not from an environmental decontamination perspective. No, I haven't.
Yeah, and then someone's asked about what do we think about the costs are likely to be, and I mean, I guess that's an unknown, isn't it, until we start seeing technologies come out.
It is, but the one thing I did read about is because you're just relying on essentially electricity and gas, there aren't expensive consumables. So if you can get that process kind of being done in a cost-effective way, I think that the authors in the commentary say that there is the potential for it to be applied to the low or middle income setting, because the generation is potentially just using things that are hopefully commonly available. And with hydrogen peroxide, it's the same with your ultraviolet light, though, I guess, isn't it? But then maybe you've got more complexities in the actual machine and the delivery mechanism. With hydrogen peroxide vapor, obviously you have to buy the consumable element to it as well. So but I mean, from what I've read, it definitely shows promise as being a cheaper environmental decontaminant. But then I guess it depends on scalability as well, doesn't it?
Yes. Do you think there's a role for it combined with other technologies?
From a disinfection perspective, do you mean, like with yeah. Yes and no. I mean, I say yes because I think I'd like to see more research done on it and see something. I'm a tremendous believer in innovation, and I think that when new technologies come along and they show promise, then there's a lot of work to do to talk about how that works in a healthcare setting. So I'd like to see, how they could potentially complement others. But like I started my talk with, I think, is this potentially something that we might see in 10 years' time replacing things like UVC or hydrogen peroxide? I'm not sure yet. So I think a lot more research needs to be done. I think all the lab testing and the kind of applications in other therapeutic use areas are promising, but it's now kind of taking it to the next stage and thinking about, okay, what does it look like in a healthcare setting?
Yes. Yeah. And obviously, there is the question, not only the question of the efficacy on the surfaces, but the interaction with those surfaces and the equipment. That's clearly a major consideration for us, isn't it? We're always very aware of what equipment can undergo what decontamination process because of degeneration. So it's not just the clinical studies and microbiological studies that are required. It's all these sort of tolerability stuff as well, I guess.
Yeah, definitely. I think we're more aware now of this term material compatibility and how different disinfectants interact with the surfaces and the sometimes really expensive medical devices that we clean them with. Ultimately, it's got to be a balance, because the whole reason why we're decontaminating them is because they pose a risk of transmission. But we've got to make sure that the disinfectants that we're using are efficacious, but also safe. So I think you're exactly right. It's there's more work to do in terms of talking about how it works in a material compatibility perspective. There's another question just asking about the age of the article, and it's published really recently, so it's 2025, and as I said, it's a commentary, and it's just looking really more, I think, to highlight awareness of it as a concept, but there's still obviously a lot more work to do in terms of making sure that it can move across from being a concept to an actual application.
Can I just ask a question about application, Phil? Because you mentioned that this could be applied as a kind of vapor or mist, or somehow captured in a liquid, or in a spray. How is that possible? I mean, it sounds too good to be true.
So the papers that I read was talking about essentially by the generation of the cold atmospheric plasma, you can do that directly into a liquid by doing some amazing physicsy stuff that I wouldn't know too much about. And the commentary doesn't really talk about how you potentially put that into a mist or a vapor. I think they were just trying to say that they know that you can generate it in a liquid form, and it's about how you can then think about how you apply that more broadly to a healthcare setting and turn it into a mist or a vapor to be able to decontaminate bigger areas such as whole bays or wards or clinical settings.
Oddly, I can get my head around more the idea of producing a vapor than I can about producing something that will go into a squirty bottle with a bit of a J cloth. So it'll be interesting to see how the whole field develops, won't it? I mean, obviously, from a commercial point of view, companies like to tie you into the procurement of disposables and consumables, don't they? They're not so keen on producing one standalone piece of equipment that lasts for 20 years. without putting a huge price tag on it at the outset, obviously. So yeah, the pricing model will be very interesting, and that will have a big impact on whether it's affordable for lower and middle income countries, won't it?
Definitely.
Can I just ask about your take on use cases, Phil? Because the way you've described this is it's an incredibly versatile approach. But where do you think is the most logical use case for this kind of technology? Would it be for daily disinfection? Would it be for terminal room disinfection? Would it be for sort of continuous dosing in high-risk settings, or an on-off kind of outbreaks? You know, where do you think the most likely win is going to be here?
What a great question. I think the reason that attracted me to the article was talking about being able to use when people are in the room. So from that perspective, if it is safe, and obviously there's more work to do, I would see it as a more continuous approach. I think the fact that there's no reported resistant mechanisms, that it has a broad mechanism of action, provided, obviously, really key that the safety is there, then I would like to think about how it could be implemented, you know, maybe routinely, whether or not that is misted or fogged into a room in a mist, you know, which isn't going to affect patients or staff continuously, or it's done, you know, as part of the kind of routine disinfection cycle. So I think the jury's still out, but I think that what I read from the promising advantages of it suggests that it might be a different way to think about our environmental decontamination. We know the environment gets recontaminated really rapidly, don't we? In a dynamic healthcare setting, when people come into contact with the environment, when they cough, they sneeze, the movement of people, etc. So I've always had this idea of, you know, self-disinfecting surfaces or continuous disinfection or residual activity. So this is why it kind of piqued my interest as maybe something that we could use frequently to keep the environmental burden low.
Yeah, sounds good. I think I'd agree with that.
Okay, well, time has passed, so I think we'll wrap it up at that point. Thanks very much, both of you, for presenting and for fielding the questions. It's been a really thought-provoking session, and I think there are things that even in, you know, resource-rich settings we can take away from that article that Jon presented, and I think that we will all be very interested to see how the cold plasma pans out. So as I mentioned earlier, the Journal of Hospital Infection is looking for some new editors. The closing date, unfortunately, is the 14th of November. But if you are interested, there's further information available on that QR code showing on the slide. And also relevant to today's topic, HIS has launched the 26 programme for the infection prevention training days, which are open to everybody. And the first in February is on antimicrobial resistance, stewardship, and the interaction with IPC. So, and I know there'll be more journal clubs to come. So, Phil, I think you've got the details, or Jon does.
Yeah, I do. Firstly, Lisa, thank you very much for chairing. I think Jon and I both had a great time. So yeah, we've got 2 journal clubs planned, which you can see on the screen here. Our next one is on the 19th of November. We'll be talking about CP drain contamination and disinfection and different methods, which I'm really interested to talk about. And then Jon is going to present one in the lead up to Christmas, talking about the economic evaluation of enhanced cleaning and disinfection of shared medical equipment, something I think that we're all in agreement we need more and more of in today's world, where we have to justify every penny that we spend. Our next slide will just show you the QR code, which takes you directly to the IPC Partners website. You can look at that and you can register for all our journal clubs just by following that QR code. But yeah, on behalf of IPC Partners and the Healthcare Infection Society, and a big thank you to Lisa once again for chairing the session. Thank you all for listening. You'll be able to see the recordings on the YouTube channel, and this recording will be up within 24 hours, and you can catch up all the journal clubs there. So yeah, wish you a good day. Thanks all for listening. Thanks again, Lisa.
Thanks both. Thanks everybody.